all four speakers. Love you all to come up. So this will be the fun part where we can all have some discussion and interaction and share some of our ideas. And Nina, just really want to thank you for your authenticity and your voice and helping us to confront things we need to confront. All right, so as they get settled, how this will work, I'm going to ask a couple questions and then hand things over to Dr. O'Hara to ask a couple questions and then to our audience. So
that was just our effort to play musical chairs for exercise.
How'd that go? And I'm seeing that 3 of you got the memo that it was red today. Red was the color. Alonzo, sorry about that.
Always on.
Let's get him a Stanford T-shirt or a hat or something. Bring some cardinal red up there. All right. So just kind of want to kick it off. You all come from different institutions, different perspectives. That was by design. Could you share with us what is your institution's vision, big picture vision, in terms of maternal and child health? And we'll start with Eliseo and work this way.
Sure. I did not talk about IMPROVE, which is a major initiative being led by National Institute of Child Health and Diana Bianchi, I believe now Shannon Zank and Janine Clayton are the co-chairs of that. And MHD and other ICs, including NHLBI, are at that table, but this effort being led, there was congressional funds appropriated in fiscal 22, $30 million for this effort. And their emphasis is going to be on figuring out what to do about the community engaged model through centers and whether or not that may overlap with the SEAL infrastructure that we have stood up. That's one of the options that's being looked at. They're also trying to recreate a technology funnel like we did for the RADx testing development to try to look for gadgets that will provide monitoring of women who are pregnant in what's called maternal deserts, maternal care deserts. I'm not such an enthusiast of that approach, but we'll see what comes out of it. That's being done through a challenge process, if you find the right tool, then you'll get and then they funded a number of R1s. So since 2020, we've received R1 applications in this topic, mostly because we put out an RFA. And even though that RFA was only one time, we've continued to get applications. Our applications are mostly in the intervention side, health services focus. And so they picked applications from different ICs, different institutes that were funded. And what will happen in fiscal 23, which we're in, will be, I think, continuing these efforts coordinated by Child Health. So.
Wonderful. That'll be great. Alonzo?
I think I'm unmiked, but you can all hear me.
I will share with you.
Oh, okay. Well, I mentioned the birth justice work, which is a very important test for us around operationalizing and measuring what the community power work does, right? So that's really a large part of what we're doing around MCH. We have a whole major programmatic area called Healthy Children and Families, which does a variety of work, increasingly aligned around community participatory response approaches to that work. We're doing more work at the local and state level. We feel like to make a difference as a national foundation, given the differences around the country, we have to invest longer in places to understand how we understand those different nuances and differences. So you will see our work on maternal and child health looking to be coalition, partnered-based work, both trying to change a narrative of vulnerable people to empowered people. So there's a narrative change research component to our MCH work, and with some targeted activities around birth justice and a large housing component in our MCH work, as well as the MCH version of what kind of institutional science knowledge building changes have to happen to create the right kind of collaborative research knowledge building process to advance this from a social justice approach. But very community centered. Someone asked me, have you guys moved away from trying to change the federal government? I think we have. The short answer is sort of, because it's very complex and subject to too much oscillation, and we found, like in my last slide, that there's much more traction and ability to make a difference in a reasonable time with philanthropic dollars when it's much more location-based. So we are really kind of getting more all in on that approach.
So first I realized my mic was on backwards, so let me just fix that. So National Partnership for Women and Families is a 50-year-old feminist advocacy organization focused on economic and health justice as two different streams of work that clearly are very intertwined. In the health justice space, which is what I direct, we have three portfolios that are also very intertwined, one of which is reproductive health and rights and justice, which clearly is under attack right now and has very clear implications on both economic justice and health justice and maternal health in particular. We have our work in health system transformation, which is like a term of art for how do we change the way we pay for and deliver healthcare so that it is higher value and addresses inequities. And then there is our maternal and child health portfolio. So one of the things that we've been doing, especially since I started about 2.5 years ago, which was in the middle of, when the pandemic just started, when there was a lot more understanding and coverage of racist violence in the country, it became very clear that we wanted to ensure that addressing racial inequities was intersected completely with our long history of addressing gender inequities, right? And centering the experience of women of color. So all of this is to say that for us, the situation in maternal and child health is kind of emblematic of how all of these things intersect, not only in the short term, but also like the impact poor outcomes in childbirth have over the longer term in a family, in a community, and the individuals involved all across those aspects. And the other thing is that for a long time, a lot of the logic behind let's solve health disparities was about, well, people are making bad choices. Right, and we even heard of that in the beginning of COVID, right? People are making bad choices, and I like to quote, Little Fires Everywhere, which if you haven't seen it, it's worth it. But there's an interaction where someone says, you didn't make good choices. You had good choices. And I think that's really important for us to understand that when we're talking about the systems, it's whether people even had the better choices to make. And we saw that ad nauseum when we were talking about how Black and Latino populations in this country were dying at extraordinary rates at the beginning of COVID, and through most of COVID until more recently. And so the interesting thing and the sad thing about the maternal health crisis is that it blows that up. It blows up the fact that, it's just let's make people have more wealth and more income and the problems will go away. Let's equalize educational opportunities and the problems will go away. And the maternal health crisis is, I think, one of the most vivid and tragic examples of the fact that a Black woman cannot educate and earn her way out of the high risk, right? And so that, I feel that very deeply because that was my experience as well, as you all heard earlier today. So what we're trying to do is make sure that we are using the maternal health example as an example of how the whole healthcare system and health has to change in the country. And so right now we are in the middle of a Robert Wood Johnson project, thank you, called Raising the Bar. And the first phase of Raising the Bar was how can healthcare as an industry, as an institution, improve the way they provide whole person care to address social drivers. And I like to use drivers, not determinants, because it seems less like fate, because it's not fate, it's the accumulation of actual decisions that human beings made to disadvantage certain people. So how can health systems, healthcare, improve that? And they came up with a bunch of principles and so forth. And then we were very involved in the community engagement and the equity side of that initial project. And now we have the part two, which is how do you, and I'm sorry I'm taking too long, but this is really fascinating. And I have to give credit to where credit is due with this dude next to me who gives money and has a big, checkbook. So it's about how do you take those principles and those roles where we identified that healthcare doesn't just provide healthcare. Healthcare has to partner with communities. Healthcare needs to use its voice and its lobbyists to advance better public policy, not just in healthcare, but in general. And healthcare is an employer, and in many places they're like the driver of economic activity where they are located. And so we are translating that into a use case of maternal health. And so right now we hope it's supposed to be done by mid next year. Examples, the guidance on how do you make sure that healthcare uses all of its power and roles in a way to specifically improve maternal and child health through their own institutional work. So we're very excited about that, and I'll stop there because I could just talk about this all day, and I know there's a deadline. So.
Well, I've just come from a university where it's really investigator-driven. And so, yes, we have actually a new executive leadership where health equity has risen to the surface, which is quite wonderful. We just held a statewide health equity summit, and maternal child health was part of that, just as other issues. And also being New Mexico, where it's a more open state, we are now the abortion providers for multiple people. Apparently, our clinics have risen by 500%. The need for support for reproductive health, and it's so they're overwhelmed, and the delay in times are incredible. But we're experiencing that dramatically. So there's an impact on our care and an impact on now what is going to, I'm having junior investigators come to me. They're wanting to do some research with community engaged way, and they're trying to figure out how to advance the maternal child health kind of agenda in this totally polarized national environment and very frightening environment. So I think it's beginning to impact universities like mine, which have a health equity agenda in this reproductive health crisis that we're facing now.
No, thank you. I'm going to hand things over to Ruth to take us to the next question, but thank you for reminding us of this rapidly changing landscape. And so good that we're having this discussion today because new challenges are coming over the horizon constantly. So helping to reorient us to be a part of the solution will be great.
Thanks so much. I think one thing hopefully you've observed is we're extraordinarily motivated here at Stanford to make the changes you've all alluded to today and all spoke about explicitly. How do we do that? How do we change academic health systems, their institutional practices, to make sure that we are engaging our communities in community-based and engaged research and empowering them? What can we actually do on the ground to make sure we're moving forward? Do you want to start, Nina, with you and go back this way?
Well, I probably talked about this already, but I think one of the strategies or the opportunities here is that there's a lot of units on campus who are really caring about this. And if they can be brought together, and I think there is an interest and there's some, but everybody works in their fragmented silos. But, it's the importance of kind of bringing together the units, not just in the medical school, but the impact lab and the design school and, and the school. I was yesterday talking with some investigators around bringing together the School of Education and the pediatrics department and looking at early childhood. Those efforts are really critical to kind of make it university-wide rather than just the voice of a single investigator saying, I need help. I need help getting to the community, or and obviously looking at how care is delivered here at Stanford is really big, so that populations and communities don't feel they're excluded, because it impacts research. Trust is never going to change unless care and research come together. And so that's a big issue for you all, I know. And I think that the idea of having data that you generate, data that's generated from the outside of what are some core strategies that can be really together collaboratively targeted to the top leadership, where the leadership is, and it seems like the leadership here is willing to listen. So you've got the opportunity here big time, and I think and incentivizing especially junior people to get involved, and I see that MCHRI has been doing that in huge ways. So I think the seeds are all, we call our network in Brazil múltiplas sementes, which is multiple seeds. I think the seeds are here. It's kind of how can they be brought together in even more targeted ways. That's what I'm perceiving as an outside partner, and that I've had the opportunity to be for the last 2 years.
Thank you. That is not generally where we focus our efforts. We're much more a policy advocacy organization. But the one thing I think I would remind people is that, in this country, given the commodification of healthcare and the power of the medical industrial complex we have in this country, got to remember that if you have a bunch of seeds, it needs to be fertilized, and in this country, it's money that's going to fertilize it, right? It's the resources. And so we can't expect anything different to happen unless we decide to deploy resources in a different way to fertilize and to drive that kind of change. And so places like, when you have champions like you all are, to be able to use your influence and bringing all the voices together so that the way things are resourced changes is the path towards actual seeing that change happen.
Such an important comment. And of course, all institutions, we're an academic Senate-run institution, we have our policies. So even at the policy change level, oftentimes that can be a very useful place to start rather than end.
Yep.
Alonzo?
This is, we just came off of a year of strategic realignment. This is a major effort of the foundation around transforming academic institutions. We call it transforming health knowledge systems generation, right? That's a philanthropic framing. But it goes back to the core of what I was saying, because we think that's fundamental. Probably what got us on this was, and I think it's always painful to talk about it, but I think you know of the infamous JAMA podcast, right? That where some colleagues, leading folks, said that medicine could not be racist, right? And so that, if you follow that, has been a complete shakeup of the leadership of JAMA. Spoke to the structural problems in the way we construct and legitimize or delegitimize knowledge. That's a root cause analysis of what the problem is. So we're trying to deal with that in a root cause way. The program that I alluded to briefly, I had to start with what I knew the best, because I'm a longtime faculty member in schools of public health. The 7 schools of public health with their accrediting body who have stepped up to be, how can we reconstruct what we think are our knowledge-building practices to train researchers in public health epidemiology. Virtually every accredited school of public health wanted to be part of this cohort. They are, and they're going to be there for 2 years, connected with a learning coalition of all the rest of the schools of public health. And the neat thing, their accrediting body is involved, and the innovations that are being discovered are going to find their way into accrediting standards. We think that's a model that works. And as you know, we talked last night about we may want to tackle medical education next. We wanted to, and because we think that's a really important thing. I think there's a great willingness, but I think that we need to have that kind of learning collaborative approach to that. 2 of those learning partnerships for schools of public health are in California. They're actually in LA, USC and UCLA. So you might want to talk to them. So that's a major part of what we're trying to do.
Thank you so much. Eliseo?
I think in brief, I would say that considering that a community-engaged model, a platform for doing research should be supported as a core research function. That's how we're moving in that direction at NIH. That's what I showed you about the SEAL initiative. And that will have a cost. It's an infrastructure that will be able to advance issues in our communities. And this is not specific just to minoritized communities. It would be in general an approach. What matters, and that built into that is relationship building over time. I think the pandemic taught us that we could do things more quickly, but it's not the normal way of doing things, and we do need to invest time, build that trust, and that this needs to be acknowledged by institutions as a legitimate scientific approach to advancing knowledge. And I think that's what I would emphasize and advocate for from NIH side.
Can I say one more thing? Sure. From what we've been, the commitment has to be at the top. It just has to be at the top. I have lots of conversations with provost. It has to be understood. It has to be driven by at the department and school level, but it has to be the commitment. I mean, that's the dynamics. Driven from the department and school level, but a clear inculcation of why this is necessary at the top decision makers.
Because that's how you get the resources you actually need to do it.
Right. The commitment, the research, the resources, the ability to realign a promotion, hiring, and tenure policies consistent with the changes you want to make. It has to go right there as well.
Tremendous. Sorry, Nina,
Well,
go ahead.
it's just finding also what the leader's vision is at the top and aligning the evidence with the community engaged evidence to that is a really important, because leaders want to have evidence to drive too. So it has to, it is stories and data, both. And that and those are both evidences. I tend to work with the term evidences. We have multiple evidences that need to rise to the top to support this change, whether it's cultural evidence, practice-based evidence, story-based evidence, and data evidence from a different kind of data.
And that's where we can help our leadership.
Yeah,
Thank you so
absolutely.
much. Now we're going to open it up to our community here today to see if any of you have questions for our panel. Give you that. Yeah, that's fine.
Thank you, Rose. Ron Ariano, Pediatrics, Neonatology. Wonderful talks, and I think the emphasis on action as a result of research, it really caught my attention. And so I would look upon this as like a phase 4. So I do a research study. I find something tremendously relevant to the community who invested and trusted me and so forth. So now what's left with implementing the action? And whose responsibility is it? I don't think it's a research foundation. Is it government? Where it comes down to, again, money. How does this happen? And if that doesn't happen, I can't see how you can sustain trust. I said we.
So one of the things that I would say is when we were trying to put together that health equity virtuous cycle, one thing that became really clear, and I have been involved with PCHRI for a long time as an advisor, having grants, and it was at the bit about what do you do with the results beyond just disseminate it out to the world and hope it's like spaghetti on a wall and hope something sticks. Like how can you actually be intentional about then packaging it and sending it in a way so that decision makers, whether that it's private decision makers in a particular hospital, state legislatures, governors, Congress, it's rare now that Congress gets anything done, but that used to be at least a target, administration, so forth. Like how then you take that information and make it usable for the decision maker. And I think that's one area where a lot of these DC-based advocacy organizations are kind of good at. But what we would find was that it just would like drop off into a black hole, and all of this really interesting data, there was very little effort to translate into, so what does that mean to how we need to pay for healthcare differently? What does that mean to how practice can be changed? And so I think that is an area that still is not getting enough attention and enough resources because it's like screaming, it's like the academics scream into a void and expect something to happen. And I've had many conversations with people in this space for a long time who are like, why don't the advocates do something? It's like, where did you publish? The New England Journal of Medicine? Do you think advocates read the New England Journal of Medicine? Like that kind of disconnect is part of what we've been trying to remedy in the work that we're doing in DC.
Thank you so much. Great answer. We have a question here and then one here.
Hi, good morning. I'm from the California Maternal Quality Care Collaborative. And I want to start by first just recognizing the Black, Hispanic, gay, lesbian, plus many other social justice leaders for many, many years who have gotten to us to this point today, first of all. Many who have given their lives on the behalf of the future. Question, so what I'm hearing this morning, this is incredible. First of all, thank you. What I'm hearing this morning is shifts in power. Shifts in power. We're all at a different part in that spectrum. Many just beginning to even think about a shift in power, to many of you who are leading efforts who are already over on this side of the spectrum. Can you each speak to that, please?
Who wants to go first?
I will, Gus. Thank you for that comment, and thank you for the contextualizing of the issue. Yeah, we talk internally about avoiding philanthropic hubris, because I come from a sector that is just has traditionally not been part of the solution, and has been overly prescriptive with pre-constructed programmatic ideas about what people should do, and even in the history of this foundation. So this journey of understanding all the things we talked about, where good idea and knowledge come from, has been part of our realizing, one, we all talked about that. Explicitly recognizing, even when we are on, I think, a good journey, there's still a power gradient anytime we walk or I walk into the room. Here, I'm with a grantee. I mean, this is a power. I think we're working it nicely, effectively, but we can't ignore it, right? We can't ignore it. So part of it is understanding that, and then that's why power building becomes part of it. But for us, and I think I have a little more flexibility than you might have around the kind of funding I can do. We're moving to a lot of general operating support. If it's a great organization with a history that is working on what we think is important, why don't we just give them some general operating support? I've convinced we've talked to our board. We can evaluate the influence and impact a general operating grant has. So it's not just giving money away, but it's a powerful acknowledgement of just the contextual history you gave of who's been working on this. It is the ultimate in trust building. We talk a lot about trust-based philanthropy. Doing more general operating cost support is a walk in the talk on trust-based philanthropy. And that can still be strategic, and it can still build evidence. So that's kind of how we're thinking about it.
Thank you so much. I just want to make sure we get to some other questions. So, yes, you had a question.
Thank you all for sharing your expertise and your bold call to action. My question is, as you think about the next evolution of community engaged research or CBPR, what role do you see our corporate partners or startup playing in this ecosystem? And specifically, what are some of the policies, internal or institutional policies, that you think would need to be in place for them to play good partners and help move the agenda forward and not act as a barrier?
Nina, do you want to take that?
Eliseo is good. Okay.
Well, I would ask you to clarify how corporate partners can help, because from my perspective at NIMHD, I don't see a very proactive community of partnerships from the corporate sector, startup or otherwise. At the NIH side, people think about corporates, it's pharma, it's drug development. And we don't do drugs at NIMHD, right? We might do trials with studies with drugs, but we don't have one disease. So we're not focused on that discovery side or that testing efficacy side that most other institutes or many institutes are. So check that box. Technology, that's another one. I think that has a lot more potential. And most of our, there is this whole small business innovation research set aside at NIH. So we're required to spend, I forget, 1.9% of our extramural budget on these grants. And, we often at NIMHC struggle to get good quality applications that are relevant. And they mostly are in the technology space, often related to electronic health record implementation issues, some self-monitoring or remote areas, patient sensors to see whether you can get, stroke faster to care when you're far from a stroke center, that kind of stuff. And so those are partners that we would, call in the corporate area. And one last comment is, we're working more on the inclusive participation of studies, of clinical studies. Everyone points to what we do at NIH. NIH funds about a third of clinical studies, clinical trials, and the participation is more inclusive than the ones that pharma funds. They're usually in their drug development. And it started off with pharma not even asking in a standardized way if, let's say, Hispanic Latino data was not part of the FDA data until 2017 because they weren't required to ask. And of course, the U.S. international basis is another. So there is room there for partnership. And I think pharma is listening to us after the pandemic. So I think there's possibilities there.
Just a little. That's such an important area. And again, I agree with you. Some of the better partnerships have been on the IT side. Google Health, Amazon Web Service, cloud support to communities to get more robust community-driven data. That's really important. But there's a very, being here in this part of the country where there's startup and gazillionaires generating probably while we've been talking today more have developed. And then they create foundations. And they're growing at a faster rate than the traditional foundations. So there's something about both the corporate involvement in this kind of issues and the foundations that they develop that come from this, that they should be part of the dialogue. I think we're going to have to grow that kind of connection and knowledge building.
We have a great opportunity here to do exactly that. Yeah. And so I'd be delighted to talk to you afterwards because I think we can educate so many of our startups, so many of our corporate partners with what we're doing and actually bring that to the table. Thanks to a tremendous panel. Can everybody give them another round of applause here?
Can I just say one thing?
Yeah, go ahead.
I just want to also say that it's really important to change the way ethics are considered and IRBs are considered. And again, from my experience of working with tribal IRBs, it's not just individual cost-benefit ratio. So corporations or whoever need to be, and maybe it can come from the academic health center, that every single IRB should require a community benefit section. I cannot go to the Navajo Nation IRB without having written an educational benefit section, a technical assistance benefit section, and how I'm going to return the data and the computers and the focus group transcripts all to their repository. That's what I'm required to do with Navajo Nation IRB. It's the gold standard in the nation, and I think academic health centers and working with corporations or startups or whoever need to shift ourselves, if it's not going to come from the federal government, around adding community benefit to requirements to investigators. And it's not only a resource issue too, it's another policy area where an academic health center could be the lead in the nation. Just think, Stanford should be the lead in the nation to add community benefit to its IRB.
Thank you so much.